Our next speaker is Dr. Osama. He is practicing as a subspecialty consultant in the section of orthopedic surgery. He's also the head section of orthopedic and currently the director of the postgraduate department. Dr. Osama.
Good afternoon, everyone. Thank you very much, Dr.sheef, for this invitation, and it's my pleasure to be with you and with your colleague today to talk about the VTE prophylactic in orthopedic surgery. To start with, we know the magnitude of the problem in the United States, that it is huge. This is one country. Just imagine all the wards. There are around 200,000 deaths secondary to the VTE result. And if we talk about the orthopedic surgery itself, we have multiple procedures that have a risk of VTE. We start with the total knee, total hip replacement, also hip fracture surgery and knee arthroscope. In total knee replacement, either it can be a total or half knee replacement. We said unicompartmental knee. In the total hip replacement, also it is a procedure that it is done, and usually the patient stay in the hospital for 4 to 5 days and discharge home, and from day one able to walk. And from the hip fracture, usually either you can fix it or replace it. Knee arthroscopy, it is a day procedure. Patient had the procedure and discharge usually in the same day, unless there is more complex procedure done during the surgery. And the last thing related to VTE incidence is lower limb extremity, mainly concentrated below the knee joints. In general, the risk factor with orthopedic patient or VTE risk, age, elderly, high risk, ethnicity, also darker skin have more risk than the white Caucasian people, genetic risk, varicose vein, previous diagnosis, cancer, previous vascular event, and paralysis, especially with the MVA and road traffic accident. Infection also is a risk, especially if you are doing revision surgery secondary to the infection of prosthesis. Obesity is a challenge. Previous deep vein thrombosis also is a risk, and diabetes mellitus. The list is huge. If we're talking about the percentage in the orthopedic patient, we can see that the asymptomatic VTE in orthopedic cases very high. Example, in a trauma can reach up to 80% deep vein thrombosis prevalence for the asymptomatic. This is why it is important to concentrate in the prophylactic. This is also the impact of VTE. We have around 70% of fatal VE detected post-mortem was neither suspected nor diagnosed. And in the autopsy, they found 63% of deep vein thrombosis case clinically undiagnosed. This is another complication can happen with VTE or deep vein thrombosis, less likely to be seen because the early management, but it can happen. It is called post-thrombosis syndrome or post-phlebitic syndrome. It's what we call it varicose venous ulcer in the middle aspect of the leg. If we try to prevent, especially in the orthopedic patient, we should think about, is it a primary prevention or secondary prevention? And in the primary prevention, it is the most important one. And secondary prevention, are we talking about diagnosis? We'll see it in the Doppler ultrasound and treatment of the subclinical VTE when it is detected in the ultrasound. This is one study published in JBJS in 2007 showed the insufficient duration of venous thromboembolism prophylactic after total hip and total knee replacement when compared with the time course of the thromboembolic event. And what they found, it is what we call the GLORY registry, Global Orthopedic Registry. They did a study for included more than 100 hospitals in the 13 countries. And the total patient is 15,000, and between total hip and total knee replacement, and the result found the VTE incidence after 3 months from the surgery is still there, higher in the total knee replacement. Mean time of VTE usually between 2 weeks to 3 weeks, and still after you discharge the patient, there is always risk of developing VTE after this kind of surgery. The patient staying in the hospital between 3 to 4 days, and there is 1/4 of patients that didn't receive the recommended prophylactic duration and the dose. This is the time course of prophylactic. You can see from day 1, 100% compliance, but with the days going, the compliance decrease either with the low molecular weight heparin or warfarin. This is a time course of prophylactic use treatment versus cumulative incidence of VTE. You can see the cumulative incidence of VTE is increasing while the patient receiving prophylactic compliance is decreasing, the cumulative incidence increasing. But in the total hip and total knee, you'll find that it is reaching to the plateau. And the plateau, they catch it with these days. They find the total hip replacement 35 days. And in the total knee replacement, they found it within 15 days. And also from the graph itself, we can see the compliance with the low molecular weight injection is higher than the warfarin taking by oral. The conclusion of the study that long term you should extend the management, or what we call the prophylactic treatment of VTE. You can extend it up to 3 weeks, 21 days after 7 to 10 days in the hospital of Clexane as prophylactic in total hip and total knee replacement. It showed that it is reduced the VTE risk even by 54% relative risk reduction without affecting the safety. This is one of the form. I appreciate Dr. AlShaya and his team to make it a mandatory to be filled by our physician in our hospital. And the form, you can see it, that it is showed that the very high risk score, more than 5, majority of the procedure is related to the orthopedic, elective knee, hip fracture, spinal injury if it is MVA, and multiple trauma. And this is a recommendation of the dose, because if it is high, it must receive prophylactic management in the VTE. In terms of a dose of low molecular weight heparin, because we'll talk now about current practice at KFMC, usually we give the 40 milligram subcutaneous once daily for the patient, and it depends between 35 days to 15 days, either total hip replacement or total knee replacement. This is just very quick review of the 10th ACCP thromboprophylactic recommendation, and they concentrated also in the total joint replacement. They mentioned in the patient undergo total hip arthroplasty or total knee arthroplasty, we recommend to have a minimum 2 weeks. No rather than not to give anything, either you can give low molecular weight heparin, Fundabranex, Apixaban, Dabigatran, and Rivaroxaban, low dose unfractionated, or vitamin K antagonist. Aspirin also is, it can be given with a good level of evidence. This is the same, talking about the duration itself, the safety, and the option that you can give it. For patients undergoing a major orthopedic, we suggest extend thromboprophylactic in the outpatient period for up to 35 days from the day of the surgery, rather than only 10 to 14 days. As I said, this is our current practice. Usually give low molecular weight heparin 12 hours before the surgery, and we start the first dose 12 to 24 hours after the surgery, and we discharge the patient with the maximum 35 days. But for the total knee replacement, usually we make it shorter to 15 days. Adjacent management with intermittent pneumatic compression device and stocking is recommended with this patient. and they are tolerated usually, especially the total hip replacement, because the procedure is high. This is the total knee replacement. Usually we give it for 15 days, and until now only we are using low molecular weight heparin. Hip fracture surgery, the minimum is 10 days. Usually we extend it to 35 days because these patients usually fragile and take time to recover. And for patients undergoing hip fracture surgery, we recommend against the use of aspirin alone, especially the hip fracture, not the arthroplasty. As we discussed, the duration, the minimum is up to 2 weeks. The maximum we give 35 days. And for total knee, we give it up to 15 days. The knee arthroscopy, it's not routinely we give the anti-venous thrombosis prophylactic management, but if there is a risk factor with the patient, we give. As we discussed with the risk factor, if there is high chance that he will develop, we give the management. For me, especially, I give the patient aspirin. I don't give them low molecular weight heparin injection motivate them to walk and TID stocking. There is a lot of study now talking about oral anticoagulant, Rivaroxaban, Apixaban, record 1, 2, concentrated in the hip, record 3 and 4 for the knee, also for the Apixaban in the advanced study. And in conclusion, that the practice start to be changed in some hospitals that start to add the oral anticoagulant rather than the low molecular weight heparin injection. And from this study, you can see that they have different kind of duration. But the major difference, it is 10 milligram Rivaroxaban medication once daily. You can give it 6 hours after a procedure, compared with the low molecular weight heparin, you give it 12 hours before the procedure itself. This is also for Apixaban. The dose is 2.5 milligram twice daily in orthopedic procedure, and you start with the first dose 12 hours after the procedure, compared with before procedure and low molecular weight heparin. And a lot of comparing result, evidence-based about the conclusion. But in general, we're talking about the safety, talking about the risk of bleeding, and until now there is no very long, result that we can compare it with the low molecular weight heparin itself. Always the new oral anticoagulant medication, talking about the monitoring itself, about the antidote availability and the drug interaction and the absorption from the stomach with other medication. This can be, further investigation and result that we should wait it as orthopedic surgeon before we practice it in that King Fahd Medical City. Thank you very much.
Now,